It's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of my clients, and the question in last week's episode was how physical therapy will help your loved one to get off the ventilator and tracheostomy. You can check out last week's episode by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to continue answering the next questions regarding James and Christine's dad in ICU who's had a hemorrhagic stroke. James and Christine's dad had a brain decompression where they evacuated a large bleed from his brain after the hemorrhagic stroke. Their dad also underwent a craniectomy, which is a partial removal of the skull to decrease the brain pressures after the bleed. James and his sister Christine were getting their dad in one of the best hospitals in the United States, the Cleveland Clinic in Ohio. In the meantime, their dad was getting a tracheostomy because he couldn't be weaned off the ventilator and the breathing tube. He also had a PEG tube for feeding inserted. He also had ongoing seizures due to the stroke, and his anti-seizure medications needed to be optimized so he could wake up and progress to neurology rehabilitation. In today's one-on-one consulting and advocacy sessions with James and his sister Christine, we look at some setbacks their dad is currently going through. He had to be put back on the ventilator due to a pneumonia, and he also ended up with a central line, also known as a CVC line, and also with an arterial line again. So in today's episode of Your Questions Answered, I answer a series of questions from James and his sister Christine again that are excerpts from various one-on-one phone and email consulting and advocacy sessions with me. And the topic this week as part of this series of one-on-one consulting and advocacy sessions is Dad developed a pneumonia and now needs to be ventilated again. What should we do to make sure he keeps improving? You can also read or watch previous episodes of this series of one-on-one consulting and advocacy sessions with James and his sister Christine if you're clicking on the relevant links below this video. And if you are watching this on YouTube, just click on the link below this video. That'll get you to our website where you can access all the other episodes of this series of questions. So, James writes, "Hi Patrick, please see my questions below. They put in an arterial line yesterday, but they never started him on any vasopressors or inotropes because I guess his blood pressure came back in the normal range on his own, but they wanted the arterial line there just in case. Do you have any idea why they gave him an IV through his neck to deliver antibiotics? I think this is what made him so agitated and angry today. I don't know why. Maybe he was in pain, but he didn't want the IV going through his neck for whatever reason. They put him back on the ventilator again last night. However, they're going to leave him off the ventilator until later all night on the tracheostomy collar, which in my opinion may be a bit soon. They are also testing his sputum for pneumonia. Right now his temperature is 98.7 Fahrenheit, which is 37.05 Celsius, which is normal. They did do a chest x-ray which was negative, but it is a good point that they should check his catheter as well. They did check his feeding tube, but it seems fine. My father is not a depressed person normally. However, if an antidepressant will help his healing, and it might be something to consider. At the moment, he seems more angry than anything else, and I'm trying to figure out where his anger is coming from. Please advise on this and let us know your thoughts. Thank you, from James. So here's my response. Hi, James. The IV in his neck is a central line, or also known as a central venous catheter or CVC line. They can administer antibiotics as well as inotropes and vasopressors via the CVC. They can administer antibiotics via a peripheral IV catheter, but not the inotropes or vasopressors. If needed, they have to be given via the central line. And even some antibiotics can only be given via a central line. And just quickly, for those of you who don't know what inotropes or vasopressors are, they are intravenous medications like noradrenaline, adrenaline, or epinephrine or norepinephrine, or dobutamine, milrinone, and they are there to support usually a low blood pressure, and it is also considered life support. Also, a low blood pressure and potential infection sometimes requires fluid boluses, and again, it's a lot easier to give it via the central line, and it just leaves more options because of more IV access lumens being readily available. On the other hand, the central line also poses a risk for infection if it stays in for more than 7 days. They would have to do a chest X-ray to confirm the right position of the central line, and also look at his chest in terms of ruling out a pneumonia or a chest infection, and also look at the effectiveness of his breathing. Placing the central line in his neck would have made him agitated, no doubt about it. They would have had to lie your dad flat for a while to insert the central line, and that's not pleasant. Testing sputum for pneumonia is good, and some of the answers will also be in his chest X-ray results. Regarding depression and anger, again, many patients in intensive care, especially after now 5 weeks, you can appreciate that as time progresses, frustration, anger, and depression may come into the mix. I am all for minimizing drugs as much as possible. If depression is real, however, an antidepressant might help in the short term. As long as he can tolerate staying off the ventilator, and as long as his oxygen saturation is greater than 92%, the chest X-ray is clear and he's not struggling to breathe. For example, his breaths per minute should be less than 30. Keeping him off the ventilator is fine. Moreover, now that he's got the arterial line, they will have all the test results readily available to gauge the effectiveness of the tracheostomy collar versus the ventilation. Having said all of that, if he has a pneumonia, putting him back on the ventilator might help by simply giving his lungs a bit of a rest, as well as added on pressure via the PEEP, which is the positive end expiratory pressure. The PEEP will help in opening up any collapsed parts of the lungs. I hope that helps, James and Christine. Give me a call if you want to discuss in more detail. So here's what James writes back. Hi Patrick, you mentioned in your email, moreover, now that he's got the arterial line, they will have all the test results readily available to gauge the effectiveness of the tracheostomy collar versus ventilation. Can you please explain this to me in more detail? Many thanks, from James and Christine. So here is my response to this question. Hi James and Christine. An arterial line, also known as an arterial catheter, will give the option for doctors and nurses to draw blood samples for testing anytime without needing to do a stab. It's effortless because of the arterial line is stuck and secured in an artery. Furthermore, unlike blood samples drawn from venous blood, arterial blood will give readings about oxygen levels as well as carbon dioxide levels in the blood. Carbon dioxide is also known as CO2. Nothing could be more accurate and also more current to assess the effectiveness of breathing in real life time, besides visibly gauging breathing efforts of your dad, such as breaths per minute, and assessing his work of breathing, including oxygen saturation on the monitor. For example, oxygen levels or PO2 levels in the arterial blood gas should be around 75 to 100 mm per mercury. Carbon dioxide levels or PCO2 levels in the arterial blood gas should be around 35 to 45 mm per mercury. Any measurements outside of those levels usually need treatment and therapy. You can find out more about arterial line and its purpose by clicking some of the links that I inserted below this video in the written version of this blog. So I inserted some links where you can read up about arterial line insertion, about the arterial catheter, and also about arterial blood gas results. Furthermore, if your dad needs inotropes or vasopressors such as norepinephrine or epinephrine, it is considered life support. Therefore, a real-time reading of your dad's blood pressure would be necessary, and the arterial line is transducing a real-time live blood pressure onto the monitor, and inotropes or vasopressors such as noradrenaline, adrenaline, epinephrine, norepinephrine, dobutamine, milrinone, dopamine, and a few more. The blood pressure can be titrated up and down according to the target blood pressure to achieve the ideal blood pressure with those medications. An arterial line can be extremely useful in sick intensive care patients, and in fact, arterial lines for sick patients in ICU are imperative. I hope this helps and it's not too technical and medical. I'm very happy to explain over the phone if it helps. And if you have watched this far, you may want to have a look at my one-on-one email and phone counseling, consulting and advocacy options. You can click on the link on the top of the website for the consulting options, and you can select from the option that works best for you. Back to James. He writes back, "Thanks again, Patrick. No, it's not too medical or too technical. Is there a method to weaning off ventilation with the data used from the arterial line, or is it simply used to monitor oxygen and carbon dioxide?" From James. And here is my response. Hi, James. When patients have prolonged times of ventilation, they often don't have an arterial line anymore because it's also an infection risk. It's good to have data and assess the weaning process against it and make changes accordingly, but it's often not necessary. If your dad, for example, had 1 day off the ventilator already, that's a very good sign. If he has to go back on it for prolonged periods, it's good to have the arterial line to make assessments and also adjustments. In order to keep weaning, I would refer you back to the attached email and follow those steps. Quote unquote, normal weaning of the ventilator with tracheostomy goes as follows. Number 1, get off the ventilator onto the tracheostomy collar for 1 to 2 hours, then back on the ventilator and assess effectiveness of such, including breathing patterns, oxygen saturation, as well as arterial blood gases whenever an arterial catheter or arterial line is present. Number 2, increase the time of the ventilator during the daytime, 1 to 2 hours off the ventilator, back to 1 to 2 hours on the ventilator, until the time of the ventilator can be gradually increased so that patients can stay off the ventilator throughout the day. Once patients can stay off the ventilator throughout the daytime and quote-unquote only need nighttime ventilation, they should be able to eventually not be needing nighttime ventilation as well. Timelines around this process may vary from a few days to a few weeks and sometimes even months. In rare cases, patients will need tracheostomy ventilation for the rest of their lives. As I mentioned before, intensive care units or intensive care treatment is often 2 steps forward and 1 step back. Therefore, if things progress for now, there may be setbacks. The weaning process should be supported by ongoing mobilization, as breathing tends to be a lot easier in a chair, which makes perfect sense, and also the breathing and respiratory muscles will be strengthened with mobilization. This should also be supported by chest physiotherapy. For the method described in this email, an arterial line is often not necessary, although preferred. I hope that makes sense. Any questions, please let me know. Take care for now. So, here is James' response. Hi Patrick, thank you for this detailed and specific information. This is very good advice. I'm just curious, why is it specifically that you are against LTAC or long-term acute care? I know why they are bad, but just wanted to hear it in your words again. Also, why do you think a step-down unit in the hospital is better? Many thanks from James and Christine. So here is my response. Hi James and Christine. Step down will keep him in hospital and close to ICU. LTAC or long-term acute care is implying long-term care. Not many families report good things about LTAC. We're having way too many inquiries from families with a loved one in LTAC. You don't want long-term ventilator weaning. Why would anybody want to have long-term care? It doesn't make sense to me. You want to focus on neurology rehab. Step down will bring him closer to that. Besides, if he does need long-term ventilation, your dad would be so much better off going home with a service like intensive care at home. I hope that helps. Any questions, please let me know. From Patrick. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly, whilst your loved one is critically ill in intensive care? You get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power, and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions. Discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Or you can call me. Find international phone numbers on the top of the website. Also, have a look at our ebook section where you get more ebooks, videos, and audio recordings, and where you can also get one-on-one consulting and advocacy with me via Skype, over the phone, or via email by clicking on the tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.